Hey Super Mamas, it's Dr. Joy here and you are watching Delivering Joy MDTV. Welcome to Super Mama Sunday, where we have been talking about taking back birth, owning your birth. Today, I'm going to be talking about the main moment. This is the event that we've all been waiting for. We've been through the pregnancy, the labor, and now it's time for the birth. So we're going to talk about different birthing options, positions, delayed cord clamping, skin to skin, breastfeeding. So we're going to talk about this magic moment. Make sure you keep watching. All right, Super Mamas. So we have made it through the pregnancy. We picked the right provider. We picked a facility where we feel safe. We created our birthing space. We made it through the labor. We decided on pain control. And now it is time for the magic moment. It's time for the birth. So this video today is all about making some decisions with regard to how you birth. So I want to make sure this is inclusive because I know that not everybody's going to have the same kind of birth. Some folks are going to end up needing a belly birth, or some folks may even need what's called an operative birth, where there's a vacuum or forceps used. So I want to make sure we include everybody in this because everybody is a super mama regardless of how you birth. Plus, we also know that some people who are having a vaginal birth might have an epidural and some people might not have an epidural. So it's just lots of different factors that go into this particular moment. So we want to be inclusive of everybody because we want everybody to benefit from this information, right? So let's start with a vaginal birth. And let's start with an epidural because that's the majority of what's going to go on. Like if we look at the average birth here in the United States. So like I said, the majority of women who are having babies in the United States are having vaginal births, and the majority of them are going to have an epidural. So if you missed last week's video on pain control, catch it right here. I talked about the epidural and I talked about how an optimal epidural gives you relief from pain, but you still are able to move your legs and you're able to lift your bottom and you have good motor skills. So you're still able to move around, but you don't feel the pain like below your breast down to your feet. So if you have a good working epudural and your legs aren't just dead, then that's ideal for when you are ready to birth your baby, when you're ready, to push your baby through the birth canal and deliver your baby. So hopefully that's the case if you are birthing with an epidural, and that allows you to have more positioning options. So with an epidural, even if you do have good motor skills, if you're still able to move your legs and your bottom, you still do not want to be trying to get up and stand up, okay? Because your legs are not really reliable because you don't have good sensation in your legs. So you don't want to be trying to stand up and squat on the floor or anything like that. There are squat bars that are available that you can actually position on a birthing bed, and you can use those to use your arms and to pull your body weight up and pull yourself into a squatting position using the foot pedals on the bed. So that's an option if you do have an epidural, but in terms of like getting up out of the bed to squat, that might not be your best move because you might end up on the floor. So, you may want to sit in a throne position with an epidural, and that's certainly possible. If your legs are really heavy and you really can't move them well, you may need a little bit of assistance to get into some of these positions, and your team can certainly help you do that. There are even some modified positions that you can use with an epidural, like all fours, and you can kind of lean over the back of the bed, put your knees in the bend of the bed, and push on all fours. You can push on your side very easily with an epidural. You can also push on your back if that's most comfortable for you. And so don't be afraid if you are placed in a position when you are ready to birth if that position does not feel good to you, if you can't seem to get good traction for your pushes, don't be afraid to ask for help to get into a different position. You know what feels good to you and what doesn't. So, take the initiative to say, hey, this feels weird. I can't get comfortable. I need to move. And, tell your team how you need to move and allow them to help you get into a different position, because everybody does not birth well on their back. Everybody doesn't birth well holding the little handlebars. Some people need to grasp behind the back of their knees, or other people don't birth well grasping behind their knees. They need to grasp the handlebars. Some people do better with the tug of war, where they grab a sheet and pull, and the nurse pulls. And so there are so many different options that you can use for positioning, even if you do have an epidural. So don't get stuck in that paradigm of you got to birth on your back and you got to do, exactly what position they put you in. There are lots of different positions that you could potentially birth in, even if you have an epidural. So next, let's talk about vaginal birthing without an epidural. So if you're doing a non-epiduralized vaginal birth, you can really birth however you want. So if you want to stand up, I've had mamas who wanted to birth standing. They want to birth, in high fowlers or like a throne position where they have the back of the bed straight up. And we've removed the end of the bed, so it's like they're sitting up in a chair, like a birthing stool. They may want to squat. They may want to birth on all fours. They may want to birth on their side. So whatever position it is that feels good to you, you may want to birth in that position. Now, one thing I've found since I've been become more comfortable birthing in different positions is that there are some positions where it's more difficult for me to help protect the perineal muscles as the baby's head is being birthed. So, that's neither here nor there, but there are some positions that can lend themselves to more vaginal tearing. Now, doesn't matter if that's the position that you feel comfortable in, you can still birth that way. But I usually just say, hey, I'm not going to really be able to give you much support in this position. So I just give you a heads up. If that's still your position, if that's your happy place, go for it. But just know that I'm not going to be able to pinch and protect for you if you're in that position, because I can't get under you to pinch and protect. And I have done some real crazy, like Jedi, what's that movie? The Matrix moves to get up under people to try to pinch and protect for them. But it's really not about me at your birth. It's about you. So we try to do whatever is necessary to get you into that comfortable position where you can really groove with your birthing. So, just, think about how you feel like you need to be in that position, and I can get there. So like I've gone outside and gotten like the little kindergarten chairs out of the lobby from the kiddie table and gotten down and gotten under people. So there are lots of ways to do that. So don't ever feel like you're pigeonholed into one birthing position. It's just that we have to think outside of our box sometimes as your OB care team to get in a position that that we need to be in to help you. If your birthing facility has tubs or water birthing pools, then you can certainly opt for those if they do perform water births. Next, let's cover operative vaginal deliveries. And an operative vaginal delivery simply means that a operative device like a vacuum or a forceps is being used to help you birth your baby. So this may be because you've been pushing for hours and the baby is close to the exit, but maybe you're exhausted and you just cannot push with the same force. Or maybe the baby's heart rate is dropping drastically with each contraction and you need to be able to have baby deliver quickly. These can be some of the reasons why someone would offer you, and I do mean offer you, a operative vaginal delivery. So there should not be things going in the vagina like vacuums or forceps unless someone has said to you, your obstetrician or your midwife in some cases has said to you, hey, I think you need some help here. I can put a vacuum in for you, or I can put forceps on for you to help you birth your baby. There can be risk of bruising to the baby's scalp. If I do this, do you want me to do this? So that should be kind of what the conversation is. And you see, that didn't even take 15 seconds. So even if the baby's heart rate is dropping, or we think that this is an emergency, there is a very quick conversation that still needs to occur, and you need to give your permission. There are some mamas who have researched, and I do recommend that you research the risks and the benefits of operative vaginal delivery, and they may say, you know what, no, I would rather just have a C-section rather than you put these metal forceps around my baby's head. You know, because sometimes forceps can injure the baby's face, the baby's head. Vacuums can sometimes cause bruising to the scalp. If you want my personal opinion, I don't like forceps. I don't put metal in the vagina. I think it really lends itself to really making some serious lacerations in the vagina. I've seen babies' scalps and faces lacerated. I'm just not a fan unless I have no other choice, and I think this baby is, you know, in a life-threatening situation. I'm not putting forceps in the vagina. It's just my personal thing. Some people may really love forceps. That might be their jam, but I just don't like it. So in my hands, a vacuum is a much safer instrument. I have very good results. I don't get a lot of vaginal lacerations with vacuums, and I use very low pressures with vacuums, and I don't use a lot of vacuums. So, I mean, I may do 1 or 2 vacuums a year. So I think that we need to be a little bit more judicious with our use of operative vaginal delivery, but that's just me. Anyway, we should have a conversation with you. That should be offered. So if we're doing that, then we should have a conversation, and you should agree that this is what we're about to do. It can certainly help in some situations and can prevent primary cesarean delivery, or can keep you from having to go back for a C-section in some situations where it looks like it's headed that way. So it kind of boils down to, do we want to try for operative vaginal delivery, or do we need to go back for urgent cesarean delivery? So that's a choice that you and the other parent may need to make, kind of in a quick succession. Last but not least, a belly birth. So you may have seen this video that I'm linking here about emergent cesarean delivery, where we're trying for a vaginal delivery and suddenly things take a turn. We maybe have been pushing for hours and baby is just not coming, and we can tell that baby may not be positioned properly to come down through the birth canal, or baby's heart rate is dropping drastically, or we think that the placenta has separated from the side of the uterus prematurely or too early. So you may have what's called placental abruption, or the cord has fallen through the cervix, and the cord, is prolapsed through, and it's an emergency. So some of these things happen, and a belly birth or a cesarean birth is necessary. So this may be the case. And when that happens, if you already have an epidural, that epidural can be dosed, meaning we push a big dose of numbing medicine through it and get you very, very numb from below the breast to the feet, and go back to the operating room for urgent section. And when we say urgent, we really mean that from the point that we notice that a cesarean delivery is, pretty much where the route that we need to go to make sure that baby comes out healthy and whole. We'd have 30 minutes from the time we make the decision to the time we make the incision. And so that's kind of what we're shooting for, because we know, based on the research that we have, that the outcomes are best if we've gotten started within 30 minutes. And so that conversation should be had with you by a member of your OB care team, and we should be headed back and kind of getting started in a timely fashion. And 30 minutes is the average. Sometimes it's a little less, sometimes it's a little longer, but that's what we're shooting for, is 30 minutes. And that really depends on where you are, the capabilities of your hospital. Like if they have 24-hour in-house people who are there in the operating room room, 24-hour in-house anesthesia. If the OB team is there 24 hours, or if it's covered by midwives and they didn't have to call in an OBGYN. So there are lots of factors that play into that, but that's kind of the goal, is that 30-minute time period. So if you don't have an epidural, ideally you have enough time to get what's called a spinal. And a spinal is very similar to an epidural, except there's no catheter placed in the epidural space. There's just some medicine that's shot in there that helps numb you very well from below the breast down to the feet, so that you can be awake and meet your baby. Lots of hospitals now are offering gentle cesarean deliveries, so you should ask about that. Gentle cesarean deliveries are where you are able to see your baby when it comes out. There's a drape, a special drape that has a little window that comes down so that you can see your baby when the baby comes out. And if you haven't seen my gentle C that I actually posted, I'll link that here for you so you can see kind of what our C-sections look like at my hospital. This was a scheduled C-section. And you can see kind of how we do that gentle cesarean. And that's really nice because it really helps connect the parents with what's going on with their baby, so they can see the baby, they can hear the baby crying. I leave a nice length of cord so that even though dad can't be at the surgical field with me to cut the cord, he can go and actually finish cutting the cord off the baby and get pictures. And we try to make it as authentic as possible for the family. And I think that that's really important, to have those rites of passage and to have those traditional things so that you're not robbed of that. I think that that's kind of like an important moment for the parent to have. So I leave that length of cord. They go over, they work with the peds team to cut that off. As long as everything is going well with the baby, we try to really get the other parent involved. And then we bring the baby over to the mom. And, if things are going well and everything's safe and stable, we try to put that baby right up on mom's chest, and we continue the surgery. So continue closing everything back up, all the layers, just like they were before we went in. And we want to allow some bonding time with baby. And then once mom's had some bonding time and we capture those special moments, then the other parent or dad will go with the nursery to admit the baby, get the weight, make sure baby looks great. And then dad can do skin to skin with the baby until mom gets to recovery. And then we bring the baby to recovery to go back to doing skin to skin with mom. Speaking of skin to skin, for our vaginal delivery mamas who have had their babies, we're going to take that baby, and hopefully most facilities now are putting that baby right on mama's belly. And so the goal here is to put baby on mama's belly, and we want to dry and stimulate. So dry baby off really well. Want to put a hat on the baby because babies lose a lot of heat from their head. Their head is the biggest part of their body, and that cap will help keep that heat in for them. And then once baby is dried off, I usually just go ahead, and if mommy is okay, I put the baby right on mommy's tummy. Once baby has been dried off and stimulated, and if the baby needs to be suctioned, we suction the mouth and the nose, put the hat on, and then I like to put baby belly to belly and chest to chest with mama to keep warm. This helps to regulate baby's body temperature, regulate blood sugars, helps regulate their breathing. And notice I didn't say anything about having dad or the other parent cut the cord yet. I like to leave my cords until they're cold and clammy, or until they stop pulsing. We have lots of research that shows that delayed cord clamping is very advantageous to the baby, because the cord is still connected to the placenta, and the placenta is still connected to mom right after she births her baby. So the baby can still get some of mom's oxygen coming through that cord. Now, we know that we should delay cord clamping by at least 1 minute, and I just leave mine attached while I do all the other work. work. So I, dry baby off. If the baby needs to be suctioned, the suction, get the hat on, let dad or the other parent take tons of pictures, or the support people get pictures. And we're just doing other stuff, congratulating. So while all that's going on, I just have baby warming up on mom, and I'm not in a hurry to do any of that stuff. So like cleaning up, amniotic fluids everywhere. So I'm doing all these other things. Is there evidence to support that leaving the cord attached longer than 1 minute is beneficial? There really isn't, but I suppose that it's probably because nobody's ever really, done any studies on it. But I just leave it alone. Like I leave it alone because I really like for the placenta to start detaching on its own. So I don't really bother with a whole lot of stuff. I also like to go ahead and start Pitocin medicine. So this is something that's debatable. There are a lot of moms who are kind of, very, very wary of Pitocin. And, you can certainly look at it both ways. During labor, Pitocin does make your contractions more intense, and it can make them come closer together. So people feel like it can cause fetal distress, like it can stress the baby out. But after birth, it helps to contract the uterus, and it helps to slow down your bleeding. There have been some small studies that have shown connections between Pitocin and postpartum depression, which is kind of interesting. And I think there could definitely be some more research in that area, but nothing that's really statistically significant has been done with those studies. So, I'm the jury's still out for me, but I do know that Pitocin helps to prevent hemorrhage. So I am a fan of preventing hemorrhage. So I like to start some Pitocin after babies are birthed. But if I have moms who adamantly disagree with that, then again, it's their body. But just so long as they understand that the risk of hemorrhage can be quite high when we don't use any sort of medication to contract the uterus. There are some herbal tinctures that can be used. So, we don't usually have access to those at the hospital, but if that's something that you're into and you want to talk to your OB care team about it and bring your own and use it, I don't think anybody would at least I wouldn't have a problem with it. I guess I can't speak for other hospitals and care teams, but that might be an option. So these are all things that you might want to consider, because these are things that most facilities are doing now. So you may want to think about what the usual steps are, and if there's anything that you don't approve of or that you're not into, you might want to think about talking to your OB care team about that, or even talking to them about their current procedures and protocols. And I know that, a lot of folks are really into delayed cord clamping. They are into allowing spontaneous separation of the placenta so that the placenta is not, manually delivered, or it's not kind of just yanked off the wall of the uterus. So I like to just massage the uterus and let the placenta spontaneously detach. It's a lot less aggressive, and I find that my blood loss is super low. Sometimes it's like, 27, 15, it's just very, very low numbers for blood loss since I've been doing that. So I like to do that, but not everybody does. So start to ask those type of questions so that you're aware and you know what's being done at your facility. And if there's something in particular that's not done, you can ask that it be done. Now, let's talk a little bit more about skin to skin. So when babies are born, they often have this white, creamy, cheesy substance called vernix. It's not dirty, y'all. It ain't dirty. I hear people all the time, oh, clean that baby up before you put it on me. We'll do our best to dry them off and kind of remove some of that when we dry them off. But vernix is actually sterile, and it is really great for your skin, but it's what keeps their skin protected, because they are actually living in water. And so that's like a skin mask that protects their skin. But vernix is actually normal. It's very healthy and it's safe for them. So don't be grossed out by it. That it's sterile. It doesn't have bacteria or anything nasty in it. And furthermore, they came out your body. So, if they nasty, does that mean you nasty? I'm just saying. So don't be hesitant to grab for your baby and pull them into your chest and love on them and be so happy and joyful in that moment. So skin to skin is where it's at. We want to try to leave them skin to skin with you for at least the first hour after birth. And within that first hour, it's a great time to initiate breastfeeding if that's what you intend to do. Do I recommend breastfeeding? You know I do. But if that's not for you and you decided that that's not what you're gonna do, no judgment. I wish you would try it though, at least just once. I try to convince everybody to just try it one time. But if that's not what you're gonna do, at least spend that bonding time skin to skin with them. And then we can plan for you to start feeding while they're awake, because that's the time when they're most awake and most alert. So, it's gonna be kind of a whirlwind time. So I often really encourage folks to keep the noise and the lights and the visitors to a minimum, because these babies just came out where it was warm and it was dark and it was quiet, and now it's loud, it's bright, it's noisy, everybody it's cold, and so try to keep their shock to the minimum and give yourself a chance to really love on them and get to bond with them and let them just feel your nearness and smell you and know that okay, I don't know where I am, but I know I'm close to my mommy. I know I'm close to my parents because I can hear them and I can feel them and I can smell them. So give them that opportunity to feel safe before you bring in the entire parade of everybody. So I know people are always excited when babies are born, but let them just kind of catch their breath, literally, because they've never even had to breathe before. They're learning how to breathe. They're learning how to open their eyes. They're just learning so many new things in that first hour. So I highly recommend that. Obviously you're gonna do what you want, but I highly recommend just give them some time to just woosah after coming out of your body, so they can just kind of get their bearings before you bombard them with a lot of people and noise and stuff. So in this first hour after birth, while you're bonding with your baby, you'll also be getting some checks. So we'll be checking your bleeding, making sure you're not bleeding too heavily. If you required any repairs of vaginal tears, that will be done. If you requested immediate postpartum birth control, that'll be done for you. And then just kind of getting you cleaned up and comfortable and, prepared for the immediate postpartum period. Some facilities have you recover and stay in that room for your postpartum period. So you do your labor, your birth, and your postpartum recovery in that same room. And then other places may take you to another room on a different floor. So whatever needs to happen in that immediate postpartum period is what will be going on. So these are things that you kind of want to keep in mind and just kind of prepare yourself for, so that you are aware of what's going on. And if you have special needs or you have things that that you need for these particular events during your stay in the hospital, you can kind of be thinking ahead about what you need and the things that you need to pack and bring with you. And so there are lots of things that you can do to kind of keep your stress level down, to kind of be prepared for what's going to be happening or what you might be asked to do or when you might be asked to move. So you want to keep everything as low stress and as chill as possible and just enjoy the moment. So I hope today's video was helpful. I hope that you learned something and that you were thinking about some things and asking some questions at your next visits. And let me know in the comments about what your desires are for your birth. I would love to engage with you on this topic. I hope you subscribe so you don't miss a single Super Mama Sunday episode, and give your girl a thumbs up if you like today's video. I'll catch you next Sunday, Super Mamas. Peace.